third tibia, non-linear deformity. Dr. Girish.
Good morning, everyone. So, topic which I would be speaking is about proximal one-third tibia deformity with distal non-union. So, he was a 28-year-old male. He presented to us with pain in the right leg since last 5 to 6 years. He had a deformity and shortening of the right lower limb. When he was 7 years old, he had a history of fall while playing, and afterwards he had fever associated with pain. He was diagnosed with osteomyelitis and was started with antibiotics. He underwent a debridement and sequestectomy at the age of 7 in 2001, and later on again a sequestectomy and a skin graft in 2021. These were his clinical pictures. As we can see, he has quite some shortening. He has varus and recurvatum in his right lower limb. The skin on the medial side was puckered and was completely thickened. And this was his walking video in which he was stooping on the right side and walking. So we did a X-ray of the right tibia, APN lateral view, in which we found out there was a proximal deformity of 27-degree varus and 20-degree of recurvatum in the proximal tibia. And he also had a non-union in the midshaft of the tibia. His hip knee ankle axis was around 165 degrees, and he had around 5 centimeter or 6 centimeter of shortening in the tibia and around 2 centimeter in the femur. So the plan initially was to do a oblique fibular osteotomy and then see if the fragments are moving around or not. If the fragments are stiff, then our plan was to do just distraction and correcting the deformity. The other thing was we had to correct the proximal deformity, so we had to do a osteotomy in the proximal region. And if the fragments were mobile, the plan was to do a resection and docking. So we did a oblique plane deformity correction planning at the proximal site, which gave us the hinge, which was in the third hole anterolateral and the fourth hole posteromedial. And he had a deformity of around 35 degree in the oblique plane. So we did a percute osteotomy in the proximal fragment and corrected that with hinge. And between the second and the third ring, we thought of correcting the deformity and doing distraction with the help of 6-axis. So this was the percutaneous osteotomy, which was done between the first and the second ring. And this was the 6-axis which was applied between the second and the third ring to correct the deformity and distraction. So in the initial first step, our plan was only to do distraction and see whether there is bone formation or not, and whether the fragments were disengaging. So after the first step got over, we could see that there was no distraction between the second and the third ring. However, the proximal deformity got corrected with the oblique plane planning and the hinges. His hip knee ankle axis now was around 179 degree. So we gave him a second plan just to do more distraction between the second and the third ring and seeing whether the fragments got disengaged. Even after the second plan got over, there was no distraction happening between the second and the third ring. And later on, we found out that the fibula, which was osteotomized, was not a complete osteotomy, and the fibula was not distracting. So we went in again and did a refibula osteotomy. And immediately after the fibula osteotomy, the fibula springed apart and there was distraction which happened. Yeah. The proximal between the first and the second ring, the deformity got corrected, and he also had shortening. So we thought of lengthening that over the straight rods between the first and the second ring. And with the 6-axis, we gave him a program to correct the deformity as well as the distraction. So we gave him around 1 centimeter of distraction and some amount of valgus correction and procurvatum correction. So this was after the first step. He had some extra valgus which happened at the non-union site, and there was some amount of translation. So we thought of giving it fine tuning, and there was a lot of distraction at the non-union site. So we thought of giving compression, correcting the valgus deformity with the same 6-axis and medial translation. And in the third step, we gave him some amount of procurvatum to make the lateral view aligned, and we gave him more compression. So this was after the compression got over. So he had around 3 mm of LLD on the right side. That was the right side was a bit longer. And these were his clinical pictures. As you can see, the knee was still flexed. So we were not very sure whether the knee flexion was because of the flexion deformity which happened during the distraction, or whether it was just the leg was a bit longer. So we gave him some time. We asked him to walk on the same 6-axis and tried to stretch out the knee flexion deformity. And we saw him after around 6 weeks. And when the flexion deformity was corrected, the limb length was almost equal. So the 6-axis was converted into straight rods, and he was allowed walking after that. So at around 6 months, the proximal osteotomy site, which was made to correct the deformity as well as for the lengthening, had healed well. The non-union site healing was not progressing at 6 months. However, he was walking fine, so we were expecting that it will also be fine. At around 8 months, the healing was still not progressing in the 3 consecutive X-rays. However, the proximal osteotomy had completely healed off. So this was his walking at around 9.5 months, and he was walking without any support. He was comfortable in walking. The X-ray still showed that the non-union side had not healed off completely. So we did a CT scan to see whether there was any cyst or there was healing in the non-union side. The CT scan suggested there was some cyst which was formed in both the AP and the lateral views. So we went ahead again and did the excision of the cyst, and the cyst was filled up with the iliac crest bone grafting. So these were his clinical picture of the incision for the bone grafting, and this was his post-op X-rays. So around 1.5 months post iliac crest bone grafting and around 11 months, these were his clinical pictures in which there was some amount of healing which was forming at the non-union side. And around 4 months, the non-union side was healing well, and he was walking also pretty well. At around 6 months, the non-union side had completely healed off. This was around 16 months post Ilizarov, but he was very comfortable walking on the frame. So we tried to do gradual loosening, that is what we call a stress test between all the rings, and he passed on the stress test pretty well. So we decided to remove the fixator, and he was made to walk with the help of a stick. And this was around 6 months post fixator removal. His leg length were completely normal. His alignment was the alignment axis was passing through the center of the knee. And this was his pre-op and the post-op walking video. So he had a very good gait after the correction of the deformity and equalizing the limb length. So the take-home message of my presentation would be that we need to restore the alignment, even though there was a non-union, but the proximal deformity had to be corrected. We should always see for the completion of the oblique fibula osteotomy, because many times the fibula tries to hitch in the correction and can cause problem, and we should graft whenever it is necessary.
Any questions, Mangal sir? Any questions from the panel? Mangal sir, Vasu sir?
So what was the reason for waiting so long? I think one of the reasons was that he was from out of town or something. So he used to
Yes, sir.
come only once in a while. So another lesson to be learned here would be probably that when that proximal osteotomy is showing signs of healing, and if the distal non-union is not keeping up with it, then maybe going in a little earlier may not be a bad idea. That saves that would save time in terms of, if you look at his fixator time was almost 16 months. So if that grafting had been done earlier, probably he would not have had to have the fixator on for so long. But otherwise, it's a good case. Just end your slideshow.
Yes, sir.
Vasu, get Vasu's thoughts on it. Amar. Vasu, I think, was driving. Amar?
So, I agree with your observation.
Have you lengthened the non-union side? Distracted the non-union side?
We had initially distracted it by around 1 centimeter, and later on we compressed it around by the same centimeter. So the non-union side was essentially later on docked only.
It was distracted only to get a little separation between the fragments, not to create the length. All the length was from the
The
osteotomy.
cyst was formed at the non-union.
Yes.
Okay. Okay. Good.
Sir, one question, sir.
Yes.
Sir, accordion maneuver here could have helped or not? And how you decide whether that will be helpful or not? Any criteria?
Not really. I don't think that the accordion is useful. The accordion serves only by you are spending more time. So you're giving time to that area which has not healed, which would otherwise heal. The other theory for the accordion, if you, I mean, not accordion, but the other thing you can do is you compress till the patient has pain. Now that is supposed to lead to that pain is some necrosis. And that necrosis then kind of metamorphoses into bone. But just pulling it apart and pushing it closer, I seriously doubt how much effect that has. And it's very difficult to prove. No, like if you get what I mean. If you have two patients
Right.
with a 1 centimeter, 2 centimeter lengthening, and one patient you are not doing any process, just holding it there, and the other guy you are compressing, then distracting, compressing, distracting. Both of them have spent, let us say, 4 weeks or 6 weeks in that process. It's quite likely, according to me, that the guy who just waited for 6 weeks also progresses. So, and this guy also, he progressed.
Recently, I had an experience.
Yeah. What was your experience?
Okay. What was your experience? Sir, yes, I had held in one case with in spite of 3 accordion times of accordion maneuver. I thought it's uniting radiologically, but while stress testing that comes to be there is some movement. Okay, that's it. Thank you.
Mangal sir, while distraction, we often see the cysts are forming in the regenerate. So, what is the treatment protocol for that? Should we wait or if the regenerate is not consolidating within a due time, then we should go for grafting, or how do we approach these cysts?
Yeah, I think if there is a cyst, my experience has been that there is a wall on that cyst, and that is never going to fill up with bone. So I will always open that, curate out that wall, and then fill it up with graft. But the problem is I can't make out whether there is a cyst or not till some time has gone by.
So I have a point in this.
Yes.
In our institute, we are doing a thesis on the same problem. Distracted gap having cyst formation because of fast distraction or over distraction and not following the protocol. These cysts are initially detected with help of an ultrasonography, then aspirated and BMAC is injected, or a PRP, whatever is available is injected. And a 3 injection protocol we are following. We're getting good results in the form that the cyst is getting filled with new bone formation. So whenever time be, I'll tell my postgraduate to share his cases.
Sure. So, but how many cases have cysts?
So it was up till now in our institute, we have 12 patients who have had this problem, but it was only at the distraction site, not at the fracture site. We are not concentrating on the fracture site, but on the rate of distraction and rate rhythm protocol not followed, forming of cyst and then aspiration and followed by BMAC.
Yeah. So I think some points there is one, you are checking it with ultrasound.
Ultrasound, yeah.
So
because it's a medical institute college, I have a facility of
correct. So you are getting earlier warning of the cyst.
Yeah.
Normally in the private sector, when the bone starts forming around the cyst and the cyst doesn't have anything, then we find that okay, there is a cyst, and then we go for maybe a CT to find out that there is a cyst, and then go ahead with further procedure. So one of the next meetings, just get your this guy, your
postgraduate. I'll tell him
postgraduate to share. Yes, Vail, you had a question.
Sir,
Last
yes, sir. Good morning, sir. Whenever we did do lengthening, they develop this FFD. Sometimes they develop this FFD. At those times, I find it difficult to assess the length, when to stop, sir. Is there, how do we go about that scenario, sir?
So one is when the patients are approaching that length, we are very pushy for them to do the physio and get straight. We have this problem more in the cosmetic stature lengthenings. And in that situation, then the only way out is to do a CT scan. Because on a CT scan, whatever the position of the leg, you can measure this tibia and that tibia. But as Girish pointed out in this case also, he had a little bit of a flexion deformity. So you can give them a little time, stop the distraction, give them a little time to correct that discrepancy. And if at all you want to make a mistake, I think up to a centimeter of shortening is not a problem. Centimeter of shortening, patients can accommodate very well without a limp. So rather than making it longer, if you want to make a mistake, make the mistake in keeping it shorter.
Well, sir, you are speaking about femoral lengthening, no?
No, all, even tibia have.
Tibia it happens.
In tibia, so equinus contracture is more common.
When we do the proximal.
Yeah, but even with the equinus, there can be a flexion deformity like this guy had. So basically what happens is if the positioning is not exactly the same, then your measurement accuracy will be limited. Then you have to go to a CT scan.
Dr. Girish, he had
Amar,
history of infection while initial treatment was taken before he approached you.
Yes, sir. He had this thing osteomyelitis at the age of 7 years, and he presented to us at 28 years. So he was pretty much fine for 20 years, and later on he had problems.
So just a thought, another thought that on day one we could have resected the bone ends and did a proximal corticogram that would have made our job pretty easier. Means considering it is a sequel of infection.
Which has cleared off.
Yes. Means still bone ends are not that healthy. Means retrospectively.
But if you see the quality of the bone over there, there was kind of a hypertrophic appearance. So yes, that point is taken. But then it means you saw the skin. The problem is I didn't want to do anything on that in terms of the skin. It was absolutely paper thin kind of skin. So I thought as jitna kam karte hain, that much is good. But the point there, the overall point that you are also making is that you have to look at ways of reducing the fixator time. In contrast to that, the fact that we put on a good fixator, he was comfortable and he was willing to wait. Still, I'm not happy with very long fixator times. Okay, our time is up now. Let's go to the next case. Who's
Mangal, how often do you see cyst in the regenerate?
Not as often as Jayant. That's why I was asking him how many cases have you seen?
Yes.
So and it is quite possible.
It depends on the rate and rhythm following, sir. The villagers who come very late, they are doing it 1 mm per day without interval of 0.25. Those patients or over distracted, these cases have the problem.
Yeah. उसको one of these breakfast meetings उसको उसी का presentation करने दो ना, then we'll discuss that in detail.
Yeah, sir. उसको बोलता हूँ बनाने को, sir.
You can start.
Yes. This 32-year-old male sustained a grade 3 compound proximal tibia fracture with extensive skin loss following a cylinder blast injury. He was referred to us by an orthopedic surgeon 2 years after having multiple surgeries done elsewhere. Immediately post-injury, he had undergone a primary plate fixation and VAC for the wound. At 4 months post-op, he developed a discharging sinus. The plate was removed and osteoclastic bone was also resected. Fibula strut graft was applied and secured with two screws and a posterior slab. At 5 days post-op, an Ilizarov fixator was applied. At 4 months post-op, the fixator was removed and a below knee cast was given. Patient was weight bearing on the cast which was later removed at 6 weeks. When the patient presented to us, he was full weight bearing with walker support. He had pain and tenderness at the skin tenting site. Clinically, there was jog of abnormal mobility in both planes. The skin on the proximal and the medial aspect of the leg was tethered to the bone. Based on our pre-op planning, the cora for the procurvatum was below the site of the non-union. There was varus on the non-union side. The left tibia was short by about 3 centimeters. However, as callus is evident, we did not have an atrophic non-union, which directed us towards alignment correction and mechanical stability. We performed a distal parafocal osteotomy 2 centimeters away from the non-union site. We constructed the hinges targeting the procurvatum. We planned sagittal correction by the hinges with 23 days of distraction on the motor for an angle of correction of about 28 degrees. Post 23 days of distraction on the motor, the varus became more apparent. We decided to apply a 6-axis or a depth fix correction system to tackle the varus, residual procurvatum, and the tibial shortening. In the first program, we corrected the 10 degrees of varus, 10 mm of translation, and 4 degree residual procurvatum with about 10 millimeters of lengthening. We further lengthened by about 7 millimeters and later compressed it by 7 millimeters. The extra lengthening and then compression was given to create a slight bulge at the regenerate and stimulate the consolidation. The fixator was dynamized at 5 months post-op and removed at 6 months. Post-removal, he has a neutral alignment on the left. He had already been counseled for the inherent varus on the right. There was no extension lag in the left knee and the flexion was up to 120 degrees. This is his latest walking video and post-op X-ray at 1 year and 5 months post-op. There are basically 3 types of osteotomies that we perform in non-unions, primarily being intrafocal. Essentially consists of resection of the entire area around the non-union. Second being transfocal, performed through the non-union site to reshape the bone ends. It is indicated for non-unions with a longitudinal or oblique fracture line to convert the shear into compressive forces. And in this case, the paltinary or parafocal osteotomy is performed 2 to 6 centimeters away from the non-union. It aims at removing all the mechanical forces acting on the non-union site and transferring it to the osteotomy site. At the same time, it allows correction of normal mechanical axis that facilitates contact between the bone ends. Parafocal osteotomy is indicated in delayed non-unions and non-unions where the mechanical movement is predominant, hypertrophic or normotrophic non-unions. It is also indicated for treating non-unions with simple or complex deformities and those with skin lesions at the affected site. Parafocal osteotomy is contraindicated for infective non-unions with extensive tissue loss. The treatment is primarily indicated for lower limb, as in the upper limb, where traction or compressive forces, depending on the weight bearing, are lacking. Paltinary recommended that parafocal osteotomy renews the physiological stimulus, eliminates the torsional movement that has a detrimental effect on bone healing. This is further improved by fibula, which acts as a lever. Biologically, vascularization by the feeding artery must be considered. The osteotomy must be performed in respect of vascularization, preferably distal to the arterial penetration of the diaphysis. It is performed 2 to 6 centimeters away from the non-union site with an osteotome, avoiding a motorized saw to prevent the bone tissue necrosis. Parafocal osteotomy acts as a normal bone tissue with good osteogenic capacities, achieving good correction both aesthetically and mechanically. With correct indications and techniques, this method has relatively low chances of regenerate failure. The Ilizarov fixator represents a natural complement to Paltinary's technique. The elasticity of these systems allows easy control of mechanical stress. This represents further stimulus to healing and helps improve weight transfer from the fixator to the bone as the consolidation proceeds. Thank you.
Good. So the important thing here was nothing was done to the non-union itself. Right? The non-union was kept as
The
it is.
non-union was left pristine. We did not even touch it during the surgery. We did a parafocal osteotomy away from the site of the non-union, and we achieved good union in the end just by mechanical alignment correction.
So this is something that Vasu and me keep talking about, parafocal. So it takes away all the deforming forces from the which are causing the non-union, and we are going through normal tissue, so it is more liable to better sort of, what is the word? It's in a better position to heal well. And just because all of the mechanical bad forces have been taken away from the non-union and the weight bearing, the non-union goes on to heal. So any questions?
Sir, in that case, the same thing should have happened in earlier cases also. So why that had failed? If you can enlighten.
The earlier case, there were two deformities. There was one deformity at the non-union, that hypertrophic non-union, and there was another deformity which was proximal to that. So the proximal osteotomy, while it is, you can call it a parafocal, it's not truly a parafocal because we were only making the proximal tibia straight over there. And the rest of the deformity was in that distal fragment which had to be corrected. That is number one. Number two,
Right.
this was not this was potentially, as Amar pointed out, the residual of an infected non-union, or this was an infected non-union. That I think that is the two differences.
Okay, sir. Yes. Thank you.
Sir, good morning.
Yes, good morning.
Yeah. See, in this parafocal, we are not opening the non-union side also at all.
No, not opening it at all.
No debridement, nothing to be done.
No, because this was I mean, we took it as a aseptic non-union.
Okay.
Which was not healing because of the poor mechanical environment.
Okay.
And it healed off with just correcting the mechanical environment.
Sorry I'm asking a question about the regenerate, the quality of the last presentation. I'm getting a lot of problem with the quality of regenerate, but I'm not able to see a kind of, in a cyst, you say we get a demarcated area, we get a clear zone around that. I'm not seeing that kind of area in the regenerate, but the regenerate is not progressing well, they're not consolidating well. One patient with Ilizarov, one patient with LRS. And I'm finding it in more cases of LRS, I'm finding the regenerate quality and the union time to union might be, I'm not able to recognize it because of it's mostly occurring like a primary union. But I'm getting a regular problem with the regenerate site with last 4 cases.
So have you changed? Before that you were okay?
Yeah.
So have you changed something?
No.
I don't know. Guwahati ka pani?
No, probably, but I think that LRS ka stiffness ko kaise kamaya ja sakta? How can we reduce the stiffness of LRS?
We try to reduce it when we want to dynamize by taking off the middle pin. After a certain period of time, once the healing, etc. is okay, we try and reduce the
middle pin
by taking off the middle pins.
Okay.
But I think mainly it is, we have not really had that kind of
Okay, I'll share those pictures.
try and build up, I mean, write up those, make those PPTs, and then one of the meetings we'll see.
Okay, thank you.
We can consider in the breakfast meeting, in addition to 3 or 4 people presenting, 1 or 2 people who have a problem case to present in 5 minutes.
Yes, sir.
In the future, we can keep that thought in mind.
Okay.
Lily, it need not be because of the over strong fixator. It can be
Loose also.
T2.
Pardon, sir, your voice was cracking that time. What did you say?
Yeah, it can be because of the instability too.
Oh, sir, you can be right, but instability can give you a different kind of a picture. This means instability, we can get more of a cyst, I think, sir.
No, sir. Whenever there's a hypertrophic regenerate, we should always rule out instability and rule out biological factors also. So both mechanical and biological factors, even low-grade infection is one of the reason for hypertrophic regenerate.
And how much tobacco is affecting the regenerate quality?
Quite a lot.
Substantially.
A lot. A lot.
But we cannot do anything to that. So means
You can-
immediately we cannot do anything because that is the.
No, preoperatively you can. I try to refuse patients who are heavily into tobacco.
And counsel
No, sir,
them
actually, I have
that
done in one case. 1 year he was resistant, he was smoking, and then finally he stopped. He got vexed up, and then he stopped, and then it united after about 6 months.
Correct.
Okay, thank you.
Okay.
Do you
Next
think
case.
anabolic steroids have any role in consolidating degenerates?
I don't think so, but I have been looking at the literature and looking at reports which say that teriparatide improves healing of the regenerate, consolidation of the regenerate. So that is something that I am looking into. Not for the non-unions, but for quicker healing of the regenerate. So that is something that we've been looking at and trying over the last, I think, 3-4 months.
But sir, very few articles are there.
For regenerate, I thought there was quite, enough to make me think that okay, we can look at it sort of. So अभी पता नहीं है. We'll see how it works out.
But I have witnessed many cases who have already been given a teriparatide for say period of 1 year also.
No, but that is different. They have been given before they came to you.
Yes,
For a bad fixation, and the surgeon is trying to heal it with the magic of teriparatide.
Yes, sir. Yes, sir.
So yeah, that is a different thing. But when you have the regenerate, if you give them that's what the articles say. So that's what we can try it out.
Yes, sir.
Sir, I say that unless the physics is corrected, chemistry will not work.
Absolutely, that is true. But I have like one patient who's 70 years old. My frame is all good. I don't see anything wrong. Patient is walking well. Regenerate is sort of lagging a little bit. There I would say, okay, let's try teriparatide to add to all of the other factors. Because if the biology is affected by age and healing potential, then it is rational for me to try it. I don't know whether it definitely works. But I have, I think, 3 or 4 patients right now on teriparatide. Okay.
Sir,
Akansha is telling us.
Sir, Pari's
Akansha
claim of
told us third time. Huh? Last comment, Amia.
Sir, Pari's claim, Dr. Abdul Bari's claim from Bangladesh, that injection of even aspirated blood in the regenerate, poor regenerate.
Yes.
What's your opinion on that?
He should, if he has good results, he should publish it. If he publishes it, then we can dissect
No,
it.
just
That is just a statement.
Hypertrophy melts with stability, sir. You asked about the hypertrophy, but it melts with stability. So once your frame is stable, it becomes within the content of the cortical, this thing. Hypertrophy melts with the stability and goes for union.
Hyper?
Hypertrophy also just disappears with the stability of the frame, with increased stability of the frame.
Yeah, but we don't have a problem with, I mean, if I have a hypertrophic regenerate, I don't have a problem. I mean, let it heal with a little extra diameter, no problem with that.
Yes, sir.
So
But,
hypertrophic
but
regenerate
it is the
usually is
non-union.
seen
If it is
for
going for non-union, then that problem comes.
Okay. So you mean the hypertrophy of instability, where
Instable.
excessive mobility leads to
Yes.
increased
Hypertrophy.
transverse diameter.
Yes.
Okay, thank you. Third case?
Sir, third case is Nikhil, sir. I'm just sharing his PPT. Sir, is the screen visible?
Yeah.
Yes.
Nikhil, sir.
Next slide.
Yes, sir.
50-year-old male in 2011 had road traffic accident and treated elsewhere by various surgeries between 2011 and 2024. He was having comminuted fracture distal femur, which was open, and open fracture distal tibia also, and crush injury leg with many soft tissue injuries. Next.
Yes.
And treated with removal of all comminution and open reduction internal fixation with LCP with gap. They don't put anything like bone cement spacer or anything. Then and or if with distal tibia with plate, and multiple plastic surgery procedures was done. And later, next slide. And later they put non-vascular fibula grafting along with the bone grafting in the same gap. Then patient allowed to walk, and patient walking and no medial support was there. Then varus is going further before bone union. And next slide. Then regenerate is pending and implant is failing, and varus is progressing with time. Then eventually after during 2023 or 24, the fracture occurred at proximal end of this fibula strut. Next slide. Then this is failed. Implant, all screws are loosened and plate exposed. Then patient is doing his activities along with this, but after fracture he had severe pain. Then present to us having discharging sinus, exposed plate since last 7 to 10 years. Then next slide.
Yes, sir.
Then we have problems with poor soft tissue, weak bone at distal femur, then poor healing potential, stiff knee, and have equinus with foot drop. And he was a farmer and doing all agriculture activities, which also prone to trauma. Next. Then we had removed the plate, debridement, all the holes, and extend the Ilizarov fixator across the knee. Knee also was stiff and patella fused to distal femur. Then next, after 3 months, the callus started to appear, bone quality improved, patient is walking, but not healing as likely normal bone. We have to extend the fixator time. Next. After 12 months, even after 12 months, the fracture line is still there. We want to dynamize, but after dynamization, patient having pain. So we again tighten the fixator and allow walking. But patient is doing his all agriculture activities since 6 months after surgery. Next slide. Just click the video. He's doing all agriculture works along with the fixator and having no issue. So we allowed him to wait for next months. Next. Then about 1.5 years, the fracture united well, and we decided to remove the fixator. Next. Just at fixator removal, patient is quite well in fixator and no skin or any other problems is there. Next. After removal, patient is walking comfortably on his limb. And doing all his agriculture activities. Next. After 2 years, but having equinus and stiff knee.
So has he told you to correct his equinus also now or no?
No,
He's
sir.
happy with this.
He is happy with equinus also.
Ankle is also stiff, no?
No, sir. Ankle is not stiff, but he is having foot drop.
Okay.
That's why he is having this footwear like this.
Okay.
A little bit shortened, but it is easy to clear his limb around the ground.
How do you differentiate between foot drop and equinus?
Sir, if passively we could correct the ankle dorsiflexion,
yes,
then it is foot drop, or if we do not, then it is equinus.
Yeah.
Hello. Good morning.
Sir, initially he was having foot drop, then ankle fix
That has solidified into equinus.
Yes, sir.
You don't have any X-rays of his tibia and all. Jaideep was pointing out that there is a little valgus at the foot. I think that maybe this was a very distal fracture. So it's quite likely that distal pilon fracture has malunited in some amount of valgus, and some of the equinus also may be from there.
Yes.
You have any X-ray of that, Nikhil?
Yes, sir. I had, but right now in the presentation is not there, sir.
Okay.
No, the difference is if you have a foot drop, you can always manage it by tendon transfers. Here you have to differentiate equinus and the foot drop separately and treat it that way.
Okay, sir.
So, moral of the story, in this multiply operated bone, as long as, and this is again one thing which comes back to the same thing, extended fixator time. But one of the ways of looking at it is, even if there is extended fixator time, as long as patient is comfortable and able to function well, it may not be necessarily such a bad thing. Especially with this kind of skin and the history of infection, trying to put, let's say, a plate inside to shorten the fixator time may be more trouble, inviting more trouble than anything else, you know. That lateral side of his thigh looks like a railway track with multiple tracks on it.
He had 13 or 14 surgeries before.
Sir, one question, sir. May I have one question? Sir, that the frame that's beyond the tibia, beyond the knee, in this case, that could have been made only in the femur also, or not?
Sir, because knee is already stiff and patella fused to distal femur.
I know.
And so
I am deliberately asking because in one case, because of the stiffness of the knee, I had to extend beyond the tibia, beyond the knee also, though there was adequate space in the femur for 2 rings, that when I put the tibia, so one frame also in the extended to tibia, that then the fracture united. That's why I'm asking Mangal sir to make his comment. When there is stiff knee in particular,
whenever the knee is stiff, this whole
because of long lever arm.
Yeah. So if you are similarly, if you are doing a non-union of the distal humerus and the elbow is stiff, the treatment of the distal end humerus should include arthrolysis of the elbow. Otherwise, the distal portion acts as a huge lever arm. So the moment you extend your fixation across that stiff joint, you are reducing the effect of the lever arm. So in general, anytime there is a stiff joint, you should go beyond that joint or take steps to ensure mobility of the joint, which I think in this case was yeah.
Yes. Only thing is, instead of one ring, we can put 2 rings, because this one ring will have a toggle effect in upper end tibia only. And regarding this extending frame across knee, in fresh fracture, even if there is a small lever arm of fragment, one can get away without extending frame beyond knee. But whenever there is an infected non-union or long-standing non-union, we need to give good lever arm of distal fragment fixation. So it is always advisable to have a frame beyond knee. And if patient is already having knee motion, and we don't want to lose that motion, then what we can do is we can remove connection between femur and tibia in between to mobilize the knee joint. So we have done so in many cases where patient removes connection on his own and do knee physiotherapy and then reapplies the connection. So just extending frame beyond knee not necessarily will give you a stiff knee. At the time of walking, he can put the connection again.
Correct.
Yeah, I agree with Amar. It is always better to have 2 rings in the whenever extend above the knee or below the knee.
Yes.
It's always better that way. And especially when the femur, most of the femoral condyle is intra-articular. When you put any wires through that area, that is intra-articular wires, joint must be spanned.
Yes. Yes.
Otherwise, it can go in for a septic arthritis in future. It all depends upon the size of the distal fragment.
Yes.
And even after removal of the frame, their knee movement must be prevented by putting appropriate brace. Otherwise, they will develop a refracture of the supracondylar area.
Yes, sir.
And ideally wait for 6 months to mobilize quadricephaloplasty and all.
Yes, sir.
Till that, I don't ask them to mobilize the knee forcefully.
Yes, sir.
That is very dangerous.
These one probably
supracondylar fractures are always troublesome.
Yes, yes. And this one is probably not the candidate for quadricephaloplasty because of multiple surgeries and extensive scarring.
No, if at all you are planning.
Yes, sir. Yes, sir.
Okay. Thank you,
Any
Nikhil.
other questions?
There is any chat? Yeah.
Next case.
Yes, sir. Next case is by Dr. Abhishek. You can share your screen.
So is my screen visible, sir?
Yep, we can see your screen.
Good morning, everyone. Today I'm going to present a case of a complex knee deformity fixed using Ilizarov Fixator. So this is a 14-year-old girl, student by occupation. There was a history of infection around the right knee 10 years back. She presented us with complaints of severe deformity of the right lower limb. As you can see, the below the knee, the foot is turned backwards, and there was a limb length discrepancy of 12 centimeters. These are the clinical images. These are the X-ray findings. There is deformity at the distal aspect of femur, due to which the knee is unstable, and there is significant limb length discrepancy. These are the CT videos. So what were the clinical challenges around this case? There was severe angular deformity, and there was knee joint subluxation. As you can see in the video, that the knee was reducing in the flex position, and whenever we tried to extend it, it subluxated and then it turned opposite side, due to which the foot has rotated backwards, and there was large limb length deformity of 12 centimeters compared to the opposite side, and the soft tissue and bone quality was also weak due to the post-infective status of the case. So what were the goals? Goal was to restore the alignment and to correct the rotation, and also at the same time to achieve the limb length equalization and to maintain the joint stability. So strategy was to combine acute correction by osteotomy and gradual correction by a Ilizarov fixator. So under CM guidance, we decided to check at which position the knee was getting reduced. The knee was getting reduced at around 130, 140 degree of knee flexion. And we decided to fix this temporarily in this reduced position by using 2 KVs, cross KVs. After this, a close wedge close wedge of bone was cut out from the distal femur aspect, and it was around 3.5 centimeters in length, and that helped in giving a partial acute correction to the deformity. The rest of the deformity was planned to be corrected by subsequent gradual correction by using a Ilizarov fixation. So we attached hinges and motor unit to the frame, and we planned for this gradual correction. In the post-operative protocol, the gradual residual deformity was corrected using Ilizarov frame. And once the deformity was corrected in alignment, then we tried to lengthen the limb. This was done using replacing the hinges with long rods, and then limb lengthening was initiated. So what were the problems encountered? Even after 4 months of distraction, the regenerate which was formed, that was poor, and we then decided to do internal stabilization using plating and to wait for bone remodeling and hypertrophy. So after 6 months of the plating, the regenerate was adequate, the bone remodeling was good, and the limb alignment was restored. There was some amount of still limb length discrepancy, but the patient was able to walk with support. At 2 years follow-up, the functional limb was achieved and patient was able to walk unaided. However, there was a stiff knee owing to the long Ilizarov fixation time, and the limb length discrepancy was also corrected to the functional range. So what was our further plan? Our further plan was to wait for the regenerate to consolidate further and to gain some amount of knee range. It was only 0 to 20 degrees at the latest visit. To gain some amount of knee range using physiotherapy. Once adequate range of motion is achieved, our plan is to further correct the residual deformity using Ilizarov fixator. So what are the learning points? The early intervention prevents severe deformity in these cases. Ilizarov technique allows us to achieve both multiplanar correction and simultaneous lengthening at the same time. We should expect multiple surgeries, multiple frame adjustment during this time. And there can be complications such as poor regenerate, and it requires patience and staged management. Thank you.
I missed a part of that talk. Your lengthening was done from a separate osteotomy? or the
So
same place where you did the excision?
So lengthening was done at the same place of excision.
Okay.
Once we corrected deformity at the same osteotomy site, we decided to replace the hinges with long rods, and then we lengthened it.
So potentially that could be one of the causes for the poor regenerate, because you've opened that up. So the biology is definitely hindered. So in such cases, it may be a good idea, one, to either do that open correction and let it heal in one go, and then do the lengthening
Separate
at a sort of
osteotomy.
separate stage. No, at a separate stage also.
Yes, sir.
Meaning, this heals and then you go back maybe 5 months, 6 months later and do the lengthening. That's one way. Technically, if it's possible, do the osteotomy and hold it at one level and do the lengthening osteotomy at another level. That's why Vasu was asking me in that first case or the second case, first case, yeah, whether we lengthened through the non-union side. That area of bone is poor quality of bone, so it will never give a good regenerate. So similarly, in your case, that would be one option. What we are doing in many shortening with not as grotesque a deformity as yours, but valgus or varus deformity in the distal femur, is we are correcting that deformity with acute correction and a plate, and then doing in the same sitting doing a lengthening proximally with a LRS. Though theoretically both the lengthening and the deformity correction can be done with the Ilizarov, at the distal area, but I find that is more useful or better in terms of retaining range of motion. Instead of using an Ilizarov and doing a gradual correction of the deformity, you can do an acute correction of the deformity with internal fixation, now that lock plates, etc. are available.
Yes, sir.
Vasu, any comments?
Yes. Here, what is your preoperative deformity?
So preoperative deformity was there was around 140 more than 90 degrees of rotation and angulation at the coda side.
No. What is the deformity?
So deformity is
The problem is, to me, you have not evaluated it properly. The deformity has not been completely studied. So when you see such a complex case, you have to actually look at, when you take the X-ray, you can see the fibula is on the medial side. In the X-ray, you can see fibula is on the medial side. So there is something serious happening there. So actually that case must be a genu valgus, purely distal femur valgus. You have to palpate the patella, de-rotate the limb so as the patella is facing the roof, and see that your angle is again looking at the roof, and take an X-ray in that. I still remember, I have a case of 170 degrees of distal femur valgus. I presented many meetings, and I've been mentioning about how to examine it, pre-operatively planning it. 360 degrees, I think you can see the 180 degree rotations. All these are the compensations. So there is primary deformity and there's a compensatory deformity. You have to differentiate, but it has not been done. So your life has been say easy by doing a resection. Resection automatically does everything. So most of the deformity courses I usually show that 170 degree valgus as a teaching purpose. How to deal with these cases. So I corrected that without any problem. I have not resected anything. And corrected double level osteotomy. I have corrected that 170 degrees of distal femur valgus. Hope you got it. Yeah.
So just share your screen, Abhishek. Let's look at your pre-op X-ray again and try to understand the points which Vasu made. So Vasu,
Yeah.
now this is, if I look at the hip X-ray here,
Yes.
I would say that this is an AP.
That's an AP.
Correct.
But look at the knee joint.
I understand. So in addition to the valgus, there is a rotational deformity which has
It is
occurred
there.
at the
Yes.
joint. Yes.
Yeah. So that has to be evaluated properly.
Yes.
So you must take an X-ray showing the femoral condyle well.
Yeah, and see
And the
what happens to the hip at that point.
Yes, at that point.
Patella is posterior, sir. That is why it looks like fibula is on the medial side.
I know, that is why the fibula is on the medial side.
Yeah.
So you have to de-rotate the limb.
Yes, yes.
The hip will allow rotations.
So he must have derotated after osteotomy. So in post of
That's right. After osteotomy, everything is easy. The main thing is we improve our skill by preoperative evaluation.
So, but this resecting this deformed part has made the morbidity quite less as compared to gradual correction. What I feel
I don't think so. No, I don't think it makes the surgery easy. With
surgery
mobility wise, knee is stiff. Ultimately, the knee is stiff.
Sir, in such cases, knee would remain stiff, whatsoever method adopted.
That's it. So there's no point in resecting it. You can save that length.
No. But see, the deformity correction part would take substantial time in such cases.
Actually not. Actually not. Because saving that 3.5 inches or centimeters of bone, that time you may not take.
Sure.
So that would get lengthened in a time frame where you are doing a deformity correction.
You can. I do even 2 or 3 osteotomies and correct it 3 different levels.
So
it's a multi-apical deformity. So multiple osteotomies should have been done with the rotation. Sir, Vasudevan sir, case was nice eye opener, which I still remember. Yes.
In these cases, I would have treated, means given choice to treat, I would have done same thing. Only thing different would be I would have done a proximal femoral osteotomy to gain the length. I would have corrected deformity the way he has corrected. And second thing, as his knee would remain stiff for his rest of life, I would have done some lengthening in tibia also, say around 4 to 6 cm till he tolerates without developing equinus.
That's what Amar, while taking that fragment out, you do one osteotomy above the fragment and below the fragment.
Yes.
So that 2 osteotomy more than enough. You can correct at these 2 levels. Make that fragment little longer.
Yes, sir.
So that's not a big deal at all. But the only thing is you need a lot of frame modification.
Yes.
That's a complex.
And in between you have to add on frames.
Right.
Yeah.
So I think the point is the Vasu was trying to make more than anything else is we should probably study these even after studying it the way that Vasu is saying. You may decide that, okay, I'm going to just shorten, like what Amar was saying. I will do the deformity correction the same way. But I think if we study that more in detail, we have expanded our understanding and knowledge for the next difficult case that comes. That is the point I think that he's trying to make.
Yes, sir.
That improves our skill.
Yes, sir.
Of recognition.
Yes. And simultaneous lengthening of tibia can also be done because
that saves
would
you
have
length. Up to 5 centimeters difference in the level of the knee will not make a big difference.
Yes.
So there's a question in the chat box. Dr. Anup Maurya has asked, how do you measure the limb lengths in such cases on both sides?
You don't measure. You know that obviously this leg is shorter. There's no doubt that the right leg is shorter. अभी वो 7 centimeters short है या 8 centimeters short है, उससे कोई फर्क नहीं पड़ता है. Once it is straight, then you are able to assess the length better. and go ahead to try and equalize it.
Yeah, we can do it all the bone ninja correction at the end of it. At the end of it, you can take the measurement.
Yeah.
Yes.
So the distorted thing itself is a problem.
Yes.
Yeah.
Hello?
Yes, sir.
Mangal sir. Hello.
Sir, I think he got a call, maybe.
Okay.
We can hear you, sir.
No, I just wanted to ask advantage of 6-axis instead of Ilizarov in this type of deformities. Is it easier doing it with 6-axis or is it easier?
Not really. It is easier in the sense that you may not require to do hardware change.
Yes, sir.
That's about it. But you still have to then understand if like you want to do it just with osteotomy and correction like Vasu said, then possibly the 6-axis may be easier. In the initial period, there may be some roadblocks because depending on the deformity, you may not be able to put a full ring, etc. Now, if you're not able to put a full ring, then the def fix may be a problem.
Yes.
But with 5/8 also we can put it.
And the problem with the def fix is it become little bit difficult when you do the deformity more than 30-35 degrees. The frame and placing will be difficult. Do the conventional way and do the fine tuning with the def fix.
So it will require a few fine tunings while patient is in frame, while correction is going on.
Yeah. So there your SUV or def fix is very useful. Because the close correction only you get by the frame, conventional methods.
Sir, how to determine the dimension of and the plane of the wedge? Because with this X-ray, it is hard.
That depends on the proper preoperative planning.
I think what Abhishek, correct me if I am wrong. What they have done is just gone to the area which seems to be the deformity, cut the bone, cut a certain amount, and then just rotated it around till it was in the right position.
Yeah.
Is that right, Abhishek?
Yes.
So like get the distal end aligned to the proximal end. And excised enough that it allows that free movement without stretching of the neurovascular bundle. Abhishek, are we right in that assessment?
I think so. You lost.
Yes, sir.
He's there, sir.
So we temporarily fixed the knee, corrected the knee that was subluxating using KVS, and then we did that derotation plus acute wedge correction.
Okay. So what Joydeep was asking was, how did you decide in any particular way, or you just took out a trapezoidal wedge and ultimately realigned the knee to the hip?
Yes, sir. That second.
Yeah.
Second thing is.
Good. So I think next time then we'll keep a couple of, what was the things we said? One is for Jayant's PG to share his stuff with us, and there was one more. Lalit to
weak regenerates.
To show his regenerate question. So yes, you can advertise it also like that. I mean, if you have a difficult case, Shamsul.
Yes, sir.
So just
put that in ASAMI group.
Put that, and then let them send that PPT to you so that you see that yes, it's everything that information you need to give them the answer is there, and then 2 cases like that also can be included. That will be a good addition.
Sure, sir.
Okay.
So,
I think.
So can I stop the live streaming?
Yeah, I think now I have to go down. I'm at Pune Trauma Orthopedic course. So I have a keynote now in another half an hour.
Mangal sir, one minute just.
Yeah.
Sir, I spoke to that stimulant guy, Sumit.
One sec.
Sir, may I just stop the live streaming 1 second?
Yeah, stop.
Yeah. Just one moment, sir.
Jaydeep,